Hello and welcome. Namaskar. This presentation is only on Chvostek sign. You all may be aware, most of you here, what exactly is a Chvostek sign and where do you find it? Now, how many of you have seen it? If you're a student, unlikely, because it will not be kept in your elective clinical postings. Or if you're an intern, you might have seen it. So I am bringing this particular video file from my personal collection, and this may be asked as a spotter in your NEET exams. So what is the clinical relevance, the causes, specificity, and the exact physiology behind Chvostek sign? So as I told you, these online sessions are strictly for teaching purposes. The clinical photos, the image files, the consent given by the patient mandates that it's used only for educational purposes. So the Chvostek sign is a clinical indicator of potential hypocalcemia. It involves twitching of facial muscles when the facial nerve is tapped, typically in front of the ear. That is where you can clinically access the facial nerve. You cannot access the facial nerve intracranially for clinical purposes. So it's obvious it's in front of the ear that you'll be able to access it. First described by Chvostek in 1876, quite a few years back. It was an observed increased mechanically irritability of the peripheral nerves in patients with latent tetany. Now suppose there is a spontaneous firing of the facial nerve, that is tetany. But you can induce this tetany with an added mechanical stimulus to your facial nerve by hitting on it in front of the ear. What is the physiological mechanism? Calcium ions stabilize neuronal excitability, the sodium gate channels. And if it is low, it leads to obvious hyperexcitability. A positive Chvostek sign indicates increased sensitivity of the facial nerve due to low calcium levels. I'll come to it later. There is a particular slide on physiology. So have a look. Don't be in a hurry. This is when your channel is closed. The sodium ion channel is closed. Look at all the players sitting here quietly. This moment has been frozen in time. So you know sodium is an extracellular ion. Similarly for calcium, potassium is here, which is your intracellular ion. Now when there is a stimulus coming, either chemically or mechanically, what will happen? These gates, these ion channels will open and let the sodium come in and potassium has to go out. I'm not going to go into details of the action potential. But when there is enough calcium here, it will stabilize the membrane. The ion channels will not easily open for flimsy stimuli. So this is the action of calcium. But when the calcium is less, it cannot stabilize and the ion channels will open up for the most simple stimuli, which is your light tapping on the facial nerve in this particular scenario. So what do? You can see the video there. You can see the eyebrows twitching. Concentrate on the image, not on the text. After some time, you will find that the twitching is not very obvious because the muscle will be in fatigue. Or sorry, the nerve will be in fatigue because of remitted stimuli. So you learned another part of physiology also. So it's twitching of facial muscles on the same side. Fine. Twitching of muscles on the same side. Now, twitching in the eyelids will be better seen. And similarly, twitching in the angle of the mouth. Not all the time, all the muscles supplied by the facial nerve have to twitch. So look at the angle of the mouth or look at the eyelid muscles or the frontalis. Okay, what is the sensitivity? It is from 0 to 100. Look at the range. And specificity is from 80 to 100. So what it tells you, a significant number of healthy individuals may exhibit a positive Chvostek sign, complicating its diagnostic utility. See? So what is the clinical significance? Traditionally, it has been associated with hypokalemia. However, recent studies have suggested it can be there even in hypercalcemia and normal calcium levels. And it can be present in conditions like migraines and hypomagnesemia. What is the limitation? It's not a definitive indicator. That is very important. It might come in your MCQs. You must understand it is not a definitive, it is not pathognomic of hypercalcemia. Negative results naturally will not exclude it. There will be high positive rates, false positive rates, especially in the younger and the female populations. Now, in this particular case, what I showed you, it justifies to call it hypocalcemia because patient has had a total thyroidectomy. You have seen the specimen there. You have seen the clinical image there. Patient has had a total thyroidectomy. But still, you need the labs to confirm hypocalcemia. Now, what are the conditions where you can get hypocalcemia? One is your hypoparathyroidism. In this case, it is following post-thyroidectomy because the parathyroids have been either injured or physiologically shut down because of ischemia. Vitamin D deficiency, that is because of reduced absorption of calcium. Kidney failure, because you need the kidneys to put the vitamin D in the active form. There are other reasons. Acute pancreatitis, lipase will act on fat and release fatty acids, which will join with calcium and form saponic acid. So calcium ion levels will be less. Respiratory acidosis, increased pH, respiratory alkalosis, sorry, increased pH will cause binding of calcium to the albumin, and your ionic calcium, which is the active agent, is not available to stabilize the neuronal membranes. So the sign is a useful tool, but it should be interpreted with caution. Further testing is mandatory. How do you treat? I have to tell you one example. I have to mention this is from the personal collection. You can see the twitching here. And in the second video, again, it's the same patient. Post-op day 3, we have treated the hypocalcemia. It has been confirmed and then treated and corrected. And you will find that there is no more twitching. So let's have a look at the videos. This is the same first video where you saw the twitching, and here you can see there is no twitching. It has got corrected. You can see the twitching here. It has got corrected. Okay. As I told you, the Chvostek sign doesn't have sensitivity. Enough people, normal people can exhibit it. So do you have a test superior to this? That is your Trousseau sign. You raise your blood pressure, or you raise the, not the blood pressure, you raise the cuff above the systolic, and you find that the wrist will go into flexion, the MP joints will go into flexion, but the fingers, the interphalangeal joints will be in extension, and the thumb also will be in flexion. So you have flexion here, and flexion here, whereas the interphalangeal joints will be in extension. This is a far better sign, but for both you need your lab reports to call it hypocalcemia. Now this is from the net. I do not have a particular image file with me, so I will be using from the net.
The hand will draw in toward the body, and flexion will occur at the wrist, thumb, and MCP joints, but the fingers will remain extended. And if nothing occurs during
Okay, now not only hypocalcemia, it can occur in hypomagnesemia, it can occur in diphtheria and measles when your calcium levels are normal, irrespective of the calcium levels. So, how exactly do you treat it? This is very important, how exactly you treat it. Now, severe hypocalcemia or symptomatic presentations like the tetany. This patient had a tetany. It was latent and you respirate it with your tap on the facial nerve. It can lead to generalized seizures, and you know generalized seizures come with their own issues. Intravenous calcium is administered, which is your calcium gluconate. It is given as a 10% solution over 5 to 10 minutes. So you got your pharmacology integration here. Not only that, you have a big patient safety indicator. It has to be given 5 to 10 minutes, not rushed into the IV line. And not only that, it has to be done with cardiac monitoring. So you got a patient safety issue factored into this scenario, and you have your pharmacology also. What happens when there is untreated hypercalcemia? It can lead to serious complications like heart failure. Your twitching of the facial muscles is the least of our problem. It is the tip of the iceberg. Only thing is, when you pick the tip of the iceberg, you can go down to the deeper life-threatening problems. So it will be heart failure, seizures, arrhythmias, bad arrhythmias without necessarily causing cardiac failure can be lethal by themselves, and laryngospasm. Now, why did I bring in laryngospasm here? Very important following thyroid or parathyroid surgery, because you will think it is a recurrent nerve injury, or you will think it's a hematoma, and your thinking will be in that line. Somebody with the laryngeal problem, immediate surgery, immediately following surgery on the neck, you will think of a recurrent laryngeal nerve or a hematoma problem there. You might not think of a laryngospasm. That's why I brought in the word laryngospasm here. So thank you very much. I will ask you to subscribe, share and like, and I have a Telegram channel. There is a quiz program going on almost every day there. Please do check it out, and please do recommend and push and nudge your friends also to join my YouTube and my Telegram channel. Thank you all very much. Please do keep the comments coming. Unless you bring the comments, I will not be able to do a better presentation each time. And thank you all very much, dear students.